Welcome to the deep dive.
Yeah.
Imagine you're reviewing a critical FTG PT-CT scan, patient with suspected recurrence, and boom, there it is, an unexpected hotspot.
Right.
Is it a new lesion? Progression? Or is it, something completely innocuous that could send you down a diagnostic rabbit hole?
It happens all the time.
Exactly. So today, we're diving deep into precisely these moments. The fascinating, sometimes, let's be honest, frustrating world of FDG PT-CT artifacts. Our mission is simple. Arm you with the sharpest insights, the most practical tools to spot these tricky interlopers, minimize their impact, and make sure you get the absolute clearest picture for your patients.
Indeed. And it's so important because while FDG PT-CT gives us these incredible functional and anatomical insights, its sensitivity means it picks up, well, more than just cancer.
Yeah.
We're talking about a whole spectrum of artifacts, physiological variants that can really confound interpretation. You can get false positives, false negatives.
And the stakes are high.
Absolutely. The clinical ramifications are profound. A misdiagnosis here, that could mean inaccurate staging, unnecessary biopsies, or even, altering a patient's entire critical management plan.
Right.
So your role as a radiologist, as nuclear medicine physicians, it isn't just pattern recognition anymore. It's really this deep dive into physics, physiology, those technical pitfalls, all to prevent errors.
So what does this mean for your daily practice when that weird hotspot pops up?
Yeah.
Well, our deep dive today is designed to empower you, help you constantly tell the difference between true pathology, benign processes, and those deceptive imaging artifacts. We're going to explore these challenges systematically. We'll break them down into, let's say, 3 big buckets: technical and acquisition artifacts, physiological uptake and normal variants, and then quantitative biases. Get ready to really boost your diagnostic confidence. Okay, let's kick off our diagnostic detective work. First up, the technical and acquisition-related artifacts. These are like the gremlins in the machine, right? Direct results of the scanner, the software, or just how the images were acquired.
Absolutely. And they can be incredibly deceptive. A really significant area here is attenuation correction artifacts. AC artifacts.
Oh, yes.
This all stems from how the CT Hounsfield units get converted into P attenuation coefficients. The challenge is current algorithms often overcorrect high HU objects that aren't bone.
Right.
And that causes these spurious bumps in FDG uptake. Or, conversely, you get dark band artifacts leading to underestimation. It's a fundamental limitation of the current CT-based AC methods.
So what are the common culprits? What throws off that AC the most? I'm guessing things like metallic implants must be way up there.
Precisely. Metallic implants and devices, think orthopedic prostheses, dental fillings, maybe even pacemakers, they're notorious. They cause these streak artifacts on the CT because of high photon absorption. So when these degraded CT images are used for AC, the metal effectively over-attenuates the PET activity nearby. And bam, artifactual hotspots.
And the danger there is?
Well, it can either hide a genuine lesion underneath it, or it can dangerously mimic pathology, like an infection around a prosthesis.
Yeah, I can see that.
And it also directly messes with your SUV accuracy. You get overestimation in the bright bands next to the metal, underestimation in the dark bands. So the pro tip here, always check the non-attenuation corrected images, the NAC PET images.
Okay, NAC check is crucial.
And also, advanced metal artifact reduction algorithms, MAR, things like iterative M or IMAR, they're showing really significant promise in cleaning this up.
Okay, metal's a big one. What about another common thing we introduced, CT contrast agents? Do they cause similar AC headaches?
They absolutely do. Dense contrast, whether it's IV or oral, can induce AC artifacts too. For instance, IV contrast. It can create these linear artifacts that look strikingly like intense FDG uptake in veins.
Oh, wow.
And oral contrast, barium or iodine, that can cause varying degrees of artifact. The clinical kicker? IV contrast can easily mimic a metastatic lymph node, say in the axilla.
Right.
And oral contrast can lead to a pretty significant overestimation of bowel FDG activity. I've seen figures up to 20% for barium.
20%, okay.
Yeah, so again, NEC PEE images are your first line of defense. Another strategy is maybe a dual CT acquisition, low-dose non-contrast CT, just for the AC, then your diagnostic contrast-enhanced CT.
Sure.
Longer term, we're hoping for even smarter software solutions.
Makes sense. So it's that dense material causing the issue. What about calcified lymph nodes then? Same kind of trap.
Exactly right. Calcified nodes, much like metal, behave similarly. They're high CT attenuation. It leads to falsely elevated FDG uptake on the ACPE images because of overcorrection. These usually look focal, and if you don't recognize them, well, that can lead to critical misdiagnosis, especially critical in lung cancer staging.
So the key is suspicion.
High clinical suspicion, absolutely, and always confirm with those NECPT images.
Got it. And one last one in this AC group. Truncation artifacts.
Yep.
Seems like a straightforward positioning issue.
It often is, yeah, but with significant consequences. Truncation happens when parts of the patient's body just extend beyond the CT field of view.
Arms down, maybe. Or a larger patient.
Exactly, and the result is you're missing attenuation values for the corresponding PT data in that area. The immediate clinical consequence. Underestimation of activity. That could lead to false negatives or really compromise your quantitative follow-up scans.
Okay, so we've covered the static technical gremlins. But what about when things move? Motion and misregistration artifacts, that sounds like a whole different challenge in hybrid PT-CT. Must be pretty common.
Oh, they certainly are. Very common, very tricky. They fundamentally pop up because of the different acquisition times. CT is fast, right? Often a breath hold. It takes minutes, usually with the patient just breathing normally, tidal breathing.
And that time gap is the problem.
That's where it starts.
This must be a huge deal in areas that move a lot, like the chest and abdomen.
Absolutely. Respiratory motion, the diaphragm moving, the chest wall moving is particularly problematic. Organs like the liver, the lungs, they move significantly between the CT and the PT acquisition.
And the result is?
Substantial misregistration. I mean, I've seen cases where it looks like the liver has shifted up into the chest cavity, spuriously, or pulmonary nodules, liver lesions, they just look displaced.
Wow.
This drastically compromises your detection sensitivity, messes up SUV accuracy, and for radiotherapy planning, it's critical because of that anatomical mismatch.
So how do we mitigate that?
Well, advising quiet respiration during the CT helps, encouraging shallow breathing during the PT-CT. But honestly, the most crucial thing, systematically correlate the PET and CT findings. Scroll through those contiguous slices, make absolutely sure things line up. It's a check you have to do every single time.
Okay, systematic correlation is key. Now, what about just general patient movement? Even tiny shifts during that long PT scan must cause issues, right? How often is that a real diagnostic headache?
You're spot on. Even subtle patient shifts, maybe they just twitch slightly, adjust for comfort, that can lead to misregistration. And it shows up as those really frustrating PE hotspots that have no corresponding CT lesion, or the other way around.
The classic PATE-positive, CT-negative finding.
Exactly. It's a genuine diagnostic dilemma, can send you on a real wild goose chase. Prevention sounds simple, but it's vital. Proper patient instruction, tell them to stay still, and making sure they're as comfortable as possible before the scan starts.
Makes sense. Okay, final group in this category, radiotracer injection-related artifacts. These sound procedural, really highlighting how crucial the nuclear medicine technologist's role is. Getting it right from the start.
Precisely. Robust training, strict adherence to standardized injection protocols. These are just as critical as calibrating the scanner, maybe even more so sometimes.
So what are the common injection issues?
Well, a classic one is FDG hot clot artifacts, sometimes called microemboli. These show up as significant focal FDG accumulations, usually in the lung parenchyma, and this is key without any corresponding CT abnormality.
Okay, hot clots in the lungs. What actually causes them? Sounds pretty dramatic.
It is. The mechanism is basically agglutination of the FDG tracer by red blood cells during the injection. They form these tiny clumps, microemboli, that literally plug up small parts of the pulmonary arterial system.
And the cause of that clumping?
Most frequent cause. Aspirating blood back into the injector syringe itself, but other things contribute. Paravenous injection, injecting too fast, patient factors like really difficult veins, using old cannulas.
Okay. And clinically, the danger is?
It can tragically lead to an erroneous diagnosis of lung metastasis. Often these clots look really hot, deceptively high SUV max.
Wow. So how do you differentiate?
Key features. Focal FDG uptake in the lung without a CT lesion, often very high metabolic activity, and crucially, they disappear if you rescan the patient later.
Okay. Rescanning can be diagnostic.
Yes. And prevention. Meticulous injection technique. Avoid extravasation, avoid blood aspiration at all costs. Always use fresh IV cannulas, no blood withdrawal before the FDG injection.
Got it. And another common and frustrating injection issue, extravasation and lymphatic tracking. This one can really mess up nodal staging, I bet.
You got it. This is when the FDG leaks out into the subcutaneous tissues right at the injection site.
The dreaded infiltration.
Exactly. And then it tracks along the lymphatic channels, causing spurious fake uptake in ipsilateral, axillary, or sometimes mediastinal lymph nodes.
So it looks like positive nodes, but it's just tracer tracking.
Precisely. This can make the study totally non-diagnostic for accurate nodal assessment in that area. Leads to critical false positive axillary uptake. Often you'll see the discordance, a small or even absent node on CT, but it's blazing hot on PT.
How do we minimize that?
Again, meticulous injection technique. And whenever it's feasible, inject on the side contralateral to any known disease, especially important breast cancer, for example.
Good tip.
And always, always clearly document the injection site on the paperwork and in the system.
Essential. Okay, so we've navigated the machine-made errors and injection mishaps. What about when something looks hot, but it's just the body doing its normal thing? Our next category, physiological uptake and normal variants. Normal biology that just happens to be hypermetabolic and can fool you.
Right, and this category, it really requires what I sometimes call an encyclopedic knowledge of normal physiological variations. Beyond just knowing anatomy, remember FDG is a glucose analog. So any tissue with increased glucose use, whether it's normal function, exercise, inflammation, it's going to take it up. It's about knowing the normal weirdness, you could say.
Okay, let's start with a big one, the musculoskeletal system. We see incidental uptake there all the time.
Indeed. Skeletal muscle uptake is usually non-pathological. It can be solitary, unilateral, but typically it's symmetric, conforms beautifully to the muscle anatomy, and crucially lacks a CT lesion.
Where do we commonly see this?
Common spots. Head and neck, think extraocular muscles, mastication muscles, especially if the patient was chewing gum or has bruxism. Post-surgery changes too.
Chewing gum.
Yep. Chest and upper arm. Respiratory muscles, pectoralis, deltoid, influenced maybe by patient training, posture, even anxiety-causing tension, abdomen, pelvis, femur, psoas, gluteus. Always ask about recent intramuscular injections there, or maybe excessive walking.
And the clinical pitfall.
It can easily be misinterpreted as a malignant tumor or maybe lymph node involvement, especially tricky post-chemotherapy when you're looking for recurrence. Differentiation relies heavily on that clinical history. Ask. Recent exercise. Chewing gum, ingestions, anxiety. And look at the pattern. Symmetric versus focal. Does it perfectly match the muscle anatomy on CT?
Got it. Clinical context is king there. What about the spinal cord? I've heard about uptake there. Seems like it could be a major red herring for Mets.
It absolutely can be. Normal physiological FDG uptake is pretty consistently seen in the cervical spinal cord, usually peaks around C4, and also in the lower thoracic cord, peaking around T11, T12. It's rare-ish, but often physiological or benign focal uptake, even in cancer patients.
Why there specifically?
Well, theories include maybe inadequate FDG clearance from the artery of Adamkiewicz, that key blood supply to the lower cord, or just increased cross-sectional area in those cervical and lumbar enlargements.
But the danger is confusing it with
Spinal cord metastases, exactly. Recognizing the subtle normal variant is crucial. It can help you minimize misdiagnosis and avoid unnecessary follow-up MRIs or even more invasive procedures.
Okay. What about other benign musculoskeletal things that might light up, like, say, an old injury or arthritis?
Yeah, focal FDG uptake can definitely be seen in degenerative or inflammatory disorders. Think adhesive capsulitis, frozen shoulder, or sequestered vertebral disc fragments, even osteonecrosis. The inherent challenge here is that diagnostic continuum. There is significant overlap between just normal physiological activity and these benign pathological conditions because both can be FDG avid.
The blurry line.
It really is. This often means you do need further diagnostic workup, maybe a dedicated MRI, sometimes even a biopsy, just to definitively rule out malignancy when you see uptick in those settings.
Okay, moving to the lymphatic system. A huge one recently, you mentioned it implicitly, post-vaccination lymphadenopathy, especially with the COVID vaccines.
That's right. It really exploded onto the scene and changed our routine checking. We now frequently see increased FDG uptake in the ipsilateral axillary lymph nodes and often diffuse splenic uptake too after recent vaccinations influenza, the COVID-19 mRNA vaccines especially.
And these nodes can look pretty convincing.
Oh yeah, they can be enlarged, intensely FDG avid, and that uptake can stick around for over a month sometimes.
Wow.
The clinical implication is enormous. leads to false positives for cancer progression, metastatic disease, potentially altering treatment plans, prompting unnecessary biopsies.
So differentiation is key.
Absolutely. Careful clinical history.
Mm.
What vaccine? When? Which arm? And look at the overall pattern that diffuse splenic uptake often accompanies the nodes. It really highlights how these pitfalls aren't static, they evolve with new medical interventions. And just a quick reminder, axillary nodes can also light up spuriously from injection extravasation, as we discussed.
Fascinating how a public health measure created such a diagnostic curveball. Are there other organs and tissues that commonly throw us off with physiological uptake?
Oh, plenty. Vocal cords, for instance. Usually symmetric uptake, but unilateral intense uptake can be compensatory if there's contralateral vocal cord paralysis, maybe from recurrent laryngeal nerve damage.
Interesting. What about the gut?
Gastrointestinal tract often has diffuse or linear normal uptake, but focal uptake in places like the GE junction, the gastric wall, rectal ampulla, anal canal, that's also often benign. Here, the pattern is generally much more important than just how intense it looks.
Okay, pattern over intensity.
Exactly. Even the liver can look inhomogeneous sometimes due to variable glucose 6-phosphatase activity. You can get this sort of noise artifact, looks like ill-defined, mild uptake, but there's no CT correlate.
And urine activity. Seems like that should be easy to spot and ignore.
Usually is, yeah, in the ureter.
Well,
But down in the urethra, especially the prostatic urethra, it can be challenging sometimes. You might see a focus of urine activity in a dilated prostatic urethra after a TORP procedure, for example. It can mimic local recurrence. Then there's brown adipose tissue. BAT uptake. Very well recognized physiological variant, typically bilateral, linear, or curvilinear in those characteristic spots. Neck, supraclavicular region, mediastinum.
usually identifiable, but
But it can still mimic pathology, especially if it presents more focally or asymmetrically.
right. And the spleen. You mentioned diffuse uptake with vaccines.
Yeah, diffuse splenic uptake can also be seen with systemic inflammatory or infectious processes. Think HIV, sarcoidosis, malaria, EBV, or after GCSF administration. Generally, the diffuse pattern and relatively lower SUV usually point towards a benign cause.
And finally, parotid glands. Incidental spots there.
Incidental lesions in the parotids are almost always benign tumors or just inflammation, but asymmetric or clearly focal uptake, that definitely warrants closer correlation.
So listening to all this, it really sounds like for so many of these physiological uptake scenarios, GI, muscle, BAT, spleen, the pattern is the key, right? Diffuse, linear, symmetric, it's specific anatomical spot. Often way more informative than just the SUV max value.
You've absolutely nailed it. High SUV max can be incredibly misleading in these contexts. Radiologists must cultivate this nuanced understanding of typical physiological patterns.
Yeah.
It really requires a shift, moving from purely quantitative assessment to a combined qualitative and quantitative approach. And often, yeah, it blurs the lines with benign inflammation, sometimes needing that extra MRI or even a biopsy to be certain malignancy isn't hiding there.
Okay. Beyond the visual artifacts and the normal body quirks, our deep dive wouldn't be complete without hitting quantitative biases. These things can significantly mess with the accuracy of SUV measurements, which, as we know, are just critical for clinical decisions.
You've hit on a really crucial point, and one that's often maybe underappreciated, the partial volume effect, PVE. It's a substantial source of quantitative bias, easily comparable in magnitude to the attenuation issues we discussed, but sometimes doesn't get the same focus.
So PVE,
Yeah.
what exactly is it?
Well, it's not just one single thing. It involves two distinct effects, really. First, there's 3D image blurring, just due to the finite spatial resolution of the PEAT scanner. Think of it like this. Small sources appear larger but dimmer than they really are, with the signal kind of spilling out beyond the actual boundaries.
Okay, blurring. And the second part?
Image sampling, sometimes called the tissue fraction effect. Because the voxel grid of the image rarely lines up perfectly with the actual tracer distribution, most voxels end up containing a mix of different tissue types. So the intensity value you get for that voxel is really just the mean signal from everything within it.
So how does this blurring and averaging, this spilling out, impact SUV and apparent tumor size, especially for small lesions?
Right. For small metabolically active lesions sitting in a colder background, PVE spreads out that signal, the result. The maximum SUV, the SUV max, appears lower than its true value.
So it makes hot things look cooler.
Exactly. Which means a small tumor can look larger because of the blurring, but paradoxically less metabolically active than it really is. And you get effects like spilling in from adjacent hot areas too, which complicates things. Necrosis within a tumor can also falsely suggest more viable tissue due to averaging.
And it affects size, too.
Yes, PVE also distorts the apparent tumor size, which is a real challenge for precise radiotherapy planning. Fundamentally, it compromises SUV accuracy, so any quantitative assessment, especially for small lesions or irregularly shaped ones, you just have to keep PVE in mind.
What factors make PVE worse?
Several things influence its magnitude. Tumor size and shape are big ones smaller, less compact tumors are more affected. The surrounding tissues matter, background activity, necrosis, the scanner's spatial resolution, obviously. Image sampling, larger pixels or thicker slices make it worse. And even how you measure it, how you define your region of interest, your ROI.
And this is where it gets super complex for tracking treatment response, right? Comparing SUVs over time, like with PERSIST criteria.
This is truly where the nuance is critical. PVE is highly dependent on tumor size and shape. So imagine a tumor shrinks with therapy. Because of PVE, you can get an erroneous decrease in the apparent uptake, the SUV, even if the tumor cell's true metabolic rate hasn't changed at all.
Wow, okay. So shrinkage itself lowers the measured SUV artifactually.
It can, yes. And conversely, a small tumor that's actually growing might appear to have falsely increased uptake just due to changing PVE. So a simple, direct comparison of SUV values from scan to scan can be profoundly misleading.
So what's the takeaway for interpreting follow-up scans?
Radiologists must consider these relative changes in PVE due to alterations in tumor size and shape when they're interpreting treatment response. You have to look beyond just the absolute SUV change. This directly impacts how we apply guidelines like PERSIST. Ignoring PVE here, that can lead to major clinical misinterpretations about whether a therapy is working or not.
Okay, PVE is a huge factor. Then there are the pharmacological and patient-specific influences, things outside the scanner that still mess with FDG biodistribution and image quality.
Absolutely. The patient's whole metabolic state is a critical determinant of diagnostic accuracy. Take metformin, for example, super common diabetes drug. It fundamentally alters glucose uptake in normal organs and in tumors.
How so?
It increases uptake in the GI tract, cerebral white matter, kidneys, but interestingly, decreases it in memory-associated parts of the brain. Myocardial uptake usually doesn't change much.
And what about its effect on tumors? Is it predictable?
Not at all. It has remarkably heterogeneous effects. It increases uptake in hepatocellular carcinoma and breast cancer, but decreases it in thyroid cancer, and seems to have no change in colon or pancreatic cancers. It can even block the effect of a high-energy diet on FDG uptake.
That's incredibly variable.
It is. So the takeaway is you need a nuanced, tissue-specific, tumor-specific understanding of these effects. While stopping metformin for 48 hours is a common recommendation, maybe a more differentiated strategy is needed depending on the clinical question.
Good point. What about just general blood glucose and insulin levels? Basic physiology, but critical for FDG.
Absolutely critical. High blood glucose directly competes with FDG for uptake into cells, right? So it just diminishes image quality overall. Less signal.
Makes sense.
Conversely, if you give insulin maybe to lower high glucose before the scan, that insulin can preferentially shunt FDG into muscle and fat cells. You end up with that diffuse linear uptake in skeletal muscle that can really obscure underlying lesions.
So patient prep is key.
It's not just logistical, it's absolutely critical for image quality. Strict fasting, meticulous glucose control, fluctuations can mimic pathology or, worse, hide it.
And finally, simple things. Patient size and arm positioning.
Hugely impactful, though simple. Image quality generally goes down as patient weight or size goes up. More scatter, more attenuation. And improper arm positioning, arms down at the side, especially for chest or abdomen scans, induces significant beam hardening and streak artifacts on the CT.
Which then messes up the PT correction.
Exactly. Especially problematic if those streaks overlap critical diagnostic areas. The consequence: compromised image quality, reduced diagnostic confidence. Simple positioning makes a big difference.
Okay, so after exploring all these intricate pitfalls, from the machine to the patient, what does this all mean for us? How do we put this into practice? This sounds like shifting to a real prevention and verification mindset for interpreting PTCT.
Exactly. It's all about proactive artifact management and then robust verification of what you're seeing. A foundational principle, maybe the single most important one, is systematic correlation of the PT and CT images. Side by side, linked cursors, scrolling.
Back to basics, essential.
Absolutely. A true pathological process usually has abnormal FDG uptake and a corresponding structural abnormality on CT. If you see a PT hotspot, but the CT is completely normal in that spot, that should immediately raise a red flag. High suspicion for an artifact or maybe just benign or physiological uptake. Meticulous scrolling through those contiguous slices is essential to confirm anatomical alignment.
And the utility of the non-attenuation corrected, the NIC images. We've mentioned them a few times as a lifesaver.
They are an indispensable tool, your diagnostic secret weapon sometimes. NSEPT images are inherently free from those AC artifacts we talked about. That makes them crucial for resolving uncertainty when you suspect contrast, metal, or maybe calcified lymph node artifacts are messing up your ACPET.
So comparing AC and NAC confirms it.
Comparing them side by side unequivocally confirms if that uptake is truly metabolic or just an artifact of the correction process. You have to look at them.
Okay, so optimizing the acquisition protocols and patient prep is really the first line of defense, preventing these things in the first place.
Paramount, absolutely. Meticulous injection technique, as we stressed, is vital to prevent hot clots and extravasation. Avoid blood aspiration, use new IV cannulas every time, no blood withdrawal before FDG.
Right.
Inject contralateral to known disease if you can, and always clearly document that injection side. For chest and upper abdomen scans, advise quiet or shallow respiration during the CT to minimize that motion misregistration.
And positioning.
Keep arms elevated, arms up, to prevent beam hardening streaks. Ensure the patient is fully within the CT field of view to avoid truncation. And, as we just discussed, strict fasting protocols, meticulous blood glucose control, they're vital to optimize FDG uptake and minimize that non-specific background noise. Understanding medication effects like metformin allows for informed decisions about stopping them.
It really paints the picture of the expert radiologist as an integrator of all this diverse data, doesn't it? Pulling all the pieces together.
You're absolutely right. The importance of the clinical history and multimodality correlation cannot be overstated. You need the full picture. A comprehensive patient history. Did they exercise recently? Chew gum. Anxious. Recent vaccinations. What meds are they on? Prior surgeries. Was the phlebotomy difficult? All these details are critical for differentiation.
So when piece is tricky,
if the PET findings are equivocal or discordant with the CT, then further investigation with other dedicated imaging is often necessary. High-res CT for a suspicious lung spot, MRI for iffy spinal cord uptake, or maybe a shoulder finding. Ultimately, it's the combination, the uptake pattern, the full patient context, and the anatomical correlation that often provides the definitive diagnosis.
and what about leveraging technology, those advanced reconstruction algorithms you mentioned, like MR?
Yes, they're increasingly important. Advancements like iterative MR, IMR significantly improve both the CT image quality and the PT quantification near metallic implants. They really enhance diagnostic confidence in those challenging cases.
Yeah.
These algorithms are actively addressing many of the challenges we've talked about, constantly pushing the boundaries.
So there you have it. It's clear the diagnostic power of FDG PCT in oncology is profoundly influenced by your accurate recognition and differentiation of all these various artifacts and physiological variants.
Sure.
These challenges, from, technical glitches in the scanner to the normal metabolic quirks of the human body, they can absolutely lead to misinterpretations, inaccurate staging, and potentially guide patient management down the wrong path.
The indispensable role of the expert radiologist really shines through here. Vigilance, critical thinking, a systematic approach to reviewing every single image, they're essential. Your ability to synthesize information from the functional PET, the anatomical CT, the patient's history, their medications, other imaging modalities, it's increasingly vital for precise, patient-centric diagnoses.
You really are an integrator.
You truly have to be an integrator of complex clinical and imaging data. A detective, really, solving the body's mysteries on the scan.
And the field isn't standing still. Nuclear medicine imaging is continuously evolving. We've got new scanner tech, advanced reconstruction algorithms like MAR, sophisticated PDD correction methods are getting better, all actively tackling many of these challenges. But here's a final, maybe provocative thought for you listening. How will you stay ahead of the curve? As new medical interventions, new therapies continue to emerge, they'll inevitably introduce novel patterns of physiological FDG uptake we haven't even seen yet.
That's a great point.
Maintaining diagnostic excellence. It truly requires a commitment to continuous learning, staying right on top of the latest research, and always questioning what you see.